So what are glycemic goals in older adults? What we do know is older adults are overtreated. Um, and this comes from the NHANES data between 2001 and 10. And if you look at the graph on the left, there are three health categories: relatively healthy, complex, intermediate, such as an ALF patient, and poor or complex patients in poor health. And they found that the percentage of people with an A1C less than 7% were pretty similar, even in people in poor health. They had over 60 or 50 to 60% had an A1C less than 7, which is not appropriate. And on the right, when you look at the same health categories, what treatments were they on, these folks who had A1C less than 7%? So a majority, if you see the light bar, a majority of them were on insulin or sulfonylureas. So overtreatment is certainly an entity that we have to be aware of as we're looking at our treatment goals. So we now need to look at what are the exact treatment goals, what are the guideline recommendations, and of course you can modify that individually. So this is from the 2021 American Diabetes Association, annual professional guidelines for people with diabetes, and their chapter on older adults is actually growing in size. So for healthy older adults, such as community living elderly with a longer life expectancy, the A1C goal is between 7 to 7.5. Okay, for complex intermediate, those are people who have some functional problems, risk of falls, hypoglycemia, co-morbidities. The goal is less than 8%. Okay, but the very complex, sick older adults who are in poor health, prognosis is poor, this is a change. There is actually no recommended A1C goal, but and not to rely just on A1C, because several factors can affect your A1C. But the idea is to stay within a range of 100 between fasting and preprandial, 100 to 180, a little bit more liberal at bedtime, and look at the glucose trends rather than look at the A1C. So now to turn to diabetes management goals from the 2016 position statement in long-term care patients. There we recognize that there are three distinct classes of patients in long-term care. Community dwelling older adults, the first line, who have the potential to be discharged, who are there for short-term rehab. Then there's long-term patients who are residing in probably for the duration of their lives, and then patients who are at the end of life. So for the first group, the community dwelling short-term rehab patients, the idea is to optimize glucose control, but to avoid relying on the A1C, because they've been in the hospital, they've had bleeding, anemia, acute kidney injury, various complications, but to keep their target blood sugars 100 to 200 or 180 if possible, okay? And in those long-term care patients, which we're familiar with, who are debilitated, have cognitive and multiple comorbidities with cognitive impairment, in 2016, the recommended A1C was less than 8.5, but use caution in interpreting the A1C. And patients at the end of life, of course, we all realize there is no role for the A1C. We want to avoid hypoglycemia and extreme hyperglycemia. We want to keep them comfortable. And the monitoring frequency is only periodic in these patients. Okay. So just to focus on patients at the end of life from the same position statement, these were the key statements from that guideline, from that statement. Focus on promoting comfort and controlling distressing symptoms, avoiding dehydration, acute care visits, or institutionalization if they're at home, preserving dignity and quality of life, and do whatever is possible to decrease the complexity of treatment. That means ACNHS AccuChecks, multiple sliding scale insulin, multi-dose insulin, protocols are not recommended, okay? And if the patient or family refuse glucose checks, medications, insulin, that is their right.